We are live, please.
Okay, so a very good evening to all of you. I welcome you all in this webinar, the first in this calendar year of Family Benefit Scheme. And it's, I'll just, and I welcome all the members here. And soon we'll be joined by some other members as well as speakers. So we have with us our chairman of FBS, Dr. Rajiv Mukherjee, and he's the director and senior consultant of Mukherjee Eye Clinics. And we also will be joined very shortly by Dr. Partha Biswas, who is the immediate past president of Aios and medical director Trinetrale. We have with us Dr. Quresh Maskati, who is immediate past chairman FBS AIOS, past president of AIOS. Then he has been president in many of the organizations and has guided many societies. We have with us a young Turk who has been the president of YOSI and is a very dynamic clinician and surgeon, Dr. Digvijay Singh, who is now treasurer of Indian Neuro-Ophthalmological Society. And of course, he has got trained at RP Center AIMS, now practicing in his own clinic. We also have with us Dr. Ranjit Manyar, who is the past treasurer of FBS. He's not just the past treasurer, he is our mentor, and he is the one who knows in and out about FBS, about many societies, and is a very extremely experienced ophthalmologist working in Mumbai. We will soon be joined by Dr. Chillikuri Sharad Babu, who is the immediate past General Secretary of FBS AIOS, and he is the Chief Medical Director of Maxivision Eye Hospitals at Warangal, and the whole group of hospitals. He is in the board of directors. He is past Rotary Governor, and we also will be joined shortly by Dr. Stanshu Mathur, who is the treasurer of FBS AIOS and director High Tech Eye Hospital, Kashipur. We have with us another young and dynamic ophthalmologist, Dr. Zain Khatib, who has got training from, say, GS Medical College and KEM Mumbai. And he has done MS ophthalmology from KIMS Hubli, and currently the executive director of Khatib Eye Clinic and Perfect Vision Center, Mumbai, and has been very active in the Young Ophthalmological Society, YOSI, and and is a very prolific surgeon and clinician. We will shortly be joined by Dr. Inder Mohan Rastogi, who is the Joint Treasurer of FBS AIOS, and Dr. Kedar Nemiwant, who is the Joint Secretary of FBS AIOS, and of course Dr. Urmil Chawla, who is the North Zone representative of FBS AIOS. I'm Dr. Rajesh Sinha. I welcome you all once again in this webinar. And now I request the chairman of FBS, Dr. Rajiv Mukherjee, to say a few words.
Thank you, Professor Rajesh. It's indeed a pleasure to have such a august body of faculty, guests, and our members with us today. And I'd welcome all to the first of the webinar series of webinars we promised to bring to you in the year 2026. With these words, Rajesh, I would request you to bring on the speakers and can we start the academic session?
Thank you. So our first speaker is Dr. Partha Biswas. He has just now joined. Dr. Partha, are you ready, or we ask someone else to start? Uh, Dr. Partha, you are mute. I I think uh, he has just now joined, and maybe he's trying to figure out his slides. So shall we start with Dr. Digvijay Singh? Okay, so I would like to invite Dr. Digvijay Singh, who will be talking about myopia control in children. And let's, I mean, it's a hot topic. It's a very popular topic. A lot of studies are being done. And let's hear from Dr. Digvijay Singh about the myopia control. Dr. Digvijay, all yours.
Sure, sir. Thank you. I hope my slides are visible.
Yes.
I'll put them in presentation mode. Yeah. So, thank FBS Aios, Professor Rajesh Sinha, and the entire team for having me here to share my thoughts on arresting progression of childhood myopia. And as rightly said by you, sir, this is a very hot topic of the day. It's also something that is we are seeing a lot and lot more about. And why are we, worried about it? Because we've seen doubling of prevalence, and the way things are going, we're going to see nearly about 50% of our school-going children having myopia within the next decade or two. And the way this is, going, there have been a lot of thoughts on risk factors, everything from the genetic to the environment, and between the environment now to a lot more of near activity, near work that's happening. Different colors of light have been associated, different wavelengths of light, different forms of visual environment. So all of those risk factors is what has caused myopia to be increasing, progressing, and the prevalence has become double, something that we used to see very often in the East Asians, and now even the Indian population is showing a fast progression of myopia in the age group of 5 to 15. So what can we do? How can we, what are the options that we have to control this myopia in children? And of course, this is the first step before we do any thought of control is to give the right prescription. So you're required to do a good cycloplegic refraction. And once you've done that to the child, you need to document whether there is any progression or not. And that's when you come to these therapeutic control options. If the myopia is not a progressive myopia, then you don't need to step in with any of these control measures right at the outset. On the onset of myopia, but this is happening when there is progression that's happening over time. And within progression, typically, you have slow progressors and fast progressors. So if you're getting about 0.5 diopters or more in a year, or if you're seeing that there's a subsequent progression on two follow-ups, then you certainly need to think of giving some of these control measures. And the first of these is optical measures, which is in the form of spectacles. And there are special types of glasses that have come into the market called myopia control glasses. I'm sure a lot of us are familiar with them now. And the very earlier thoughts used to be that it was accommodative lag that was causing myopia. So earlier on, bifocal glasses or progressive addition lenses were used in the glasses, but now we have a lot of these defocus incorporating glasses or glasses with highly aspheric lenslets, and I'll show you those in the subsequent slides that have been available. Other than that, you have contact lens options, which is both orthokeratology, and again, we'll discuss some of this, and multifocal soft contact lenses. And of course, pharmacological intervention in the form of low dose atropine, which is now available in different doses, 0.01, 0.05%. Both are available in India on a commercial basis, but of course, you can make in between doses as well, in your clinics. These are the other doses are off label use at the moment. And of course, the very important part of it is the environment or the lifestyle changes that are important, because till you take care of what is causing the myopia to progress, it's very difficult to arrest the progression. So let's look at the different types of glasses. And these acronyms that I've got here is what you will see. You have bifocal glasses with progressive addition lenses. You've got glasses which have got this defocus incorporating multifocal segments. You've got highly aspherical lenslets. You've got the care technology or the dot, which are those are cylinders, and I'll show these in the subsequent slides. You've got this dot technology that is coming in, and each of these is proprietary technology of some company or the other that has done research on it. So how they work is that they are going to, one, take care of the accommodative lag, but they essentially are going to create a peripheral defocus. Now think of the globe. It's got a curved back surface on the retina. So when there is a plane of light that is focusing on the curved surface, some of the light is going to focus beyond the retina, and that itself is an impetus or a stimulus for the eyeball to grow longer, or the axial length to grow up. So these glasses will create some defocus in the periphery so that the light does not go beyond, and that defocus just in front of the retina is what keeps the eye from growing longer. So that's just a very layman or a simplistic way to understand how these glasses are working. And among them, one of the first that had come out was these, by Hoya company, which was basically these DIMS glasses. And so they had a central clear zone, and then they had these peripheral segments, which were having a progressive plus addition over time. So this is creating a hyperopic defocus going ahead from the mid to the periphery. Of course, the center is clear. So there is a slight defocus, and children may initially have trouble, in playing sports, but in most cases, they tolerate these glasses very well. And these glasses were shown in their studies to have about 60% efficacy. And you've also got studies which are now 5 years or longer, and they have been showing that there is some improvement in or reduction in the progression over time. A different technology, which is the HALT technology, again is available commercially, and here what you're getting are these highly aspherical lenslets that are put around the central clear zone. And again, the purpose or the idea is to create a defocus, and these are more tightly bound, and they can create an additional defocus, and they're supposed to have further efficacy. Also, newer technology in this is now coming further on, where they've got more tightly packed lenslets. So the this again has been shown to be very efficacious, roughly in the similar range as the previous technology, which was the DIMS technology. And this is the CARE technology, which is available again by an international brand, where you've got these cylindrical lenslets that are creating again a defocus, as you can see. Do remember, in all these glasses, you've got a central clear zone, and the clear zone has to be adequate to allow the child to function. But if it's too large a clear zone, then again, you lose some of the impacts of the defocus. So these glasses have been specially manufactured and are customized and available usually in powers up to for even high myopes now, and a reasonable amount of cylinder can be covered in them. Some of them come in photochromatic as well. And again, we see that lighting plays an important role for myopia progression. So that's important. And then you've got these dots technology, which is, again, coming out in the market very shortly, where in place of these cylinders, all lenslets, you've got dots which are creating the blur or the defocus. And these are again supposed to be almost as efficacious. So each of these organizations, each of these companies in their own studies is showing roughly an efficacy anywhere between 50 to 70% based upon the type of glasses or the length or the patient population that they choose. Similar to so that was about the basic spectacles. And of course, like I said, some cases you have to give bifocals where there's a lot of accommodative lag that is causing myopia. So the best way to decide whether you want to give the spectacle or the optical form of correction of myopia is to do a peripheral refraction, which is doing a refraction of the center and then a refraction at a certain angle to get an idea if there is that defocus difference. And this is something that we these days do. But generally speaking, these are available now with all opticals, and it is a good idea. There is, of course, a cost factor that is involved in these cases. Then you've got contact lenses, which should be multifocal contact lenses, just like you've got the glasses with the addition of the plus additions, and those are available. And then you've got these EDOF contact lenses, which again have an enhanced depth of focus. These are soft contact lenses. And you've got the ortho-K lenses, which are firm lenses that are put overnight in the child's eyes, and they form, you can see that these ortho-K lenses will create a flattening of the cornea, and over time, they not only control myopia, sometimes even a reversal of the myopia comes in, and the dependence on the glasses reduces during the day. So the child will wear it overnight, and during the day, there'll be no need or limited need for glasses. By evening, the power tends to come back because this is a reversible sort of correction that is happening to the cornea by creating a flattening. But these lenses, again, have been shown in studies to be fairly efficacious. And I'll come to a combined efficacy of each of these in the slide at the very end. What is more, as ophthalmologists, probably what is also very important for us to know is the pharmacological management. And this has been done by atropine, which is a non-selective muscarinic anti-muscarinic blocker, and it is a tried and tested drug. We know it's been around in the market for a very long time. It's a very easy to use drug. It is currently available commercially in 0.01 and 0.05% strengths. And the intermittent strengths have also been tested. But the idea of this is that you need to put this once at bedtime before the child goes off to sleep. And this is going to work on reducing the axial length elongation again. There have been studies which have used it twice, but essentially one is what is the standard that we're using as of now. The exact pathogenesis is not very sure, but there are changes that it does to the sclera choroid complex, and that is what prevents the lengthening of the eyeball. Ultimately, this is all working for axial myopia. So mind you, this is important. This may not have any efficacy on myopia, which is secondary to, let's say, retinopathy of prematurity or any other cause, but these are primary axial myopias or myopias where the eyeball length is long that are being treated through this. Of course, atropine does carry certain minor adverse effects, which could be stinging, burning. Rarely, there are some allergies that may happen. And of course, long-term use is required, and that's one of the problems with atropine. And the most important thing that we've realized over time, and this has come out through studies like the ATOM study, which is basically atropine for the treatment of myopia studies. There were ATOM 1, 2, and so they've been, I'll probably briefly come to those studies as well. And so they have shown that there is a rebound phenomena. So whenever you stop using this atropine at bedtime, the chances of the power coming back are there. So now recently, and I think this is something the AIOS has come up with guidelines on how to, as part of that team, on how to give atropine, how to withdraw the atropine. I think that will be shared with all of our members very soon. The idea is that you cannot suddenly stop atropine, and this is one of the mistakes that happens very often, that a child is using for 2 3 months, 6 months, suddenly they will stop and the power comes on and they say it was not effective. So it has to be used in a certain way. And one of the other things that's important is that there are non-responders, so it doesn't work for every case, and one has to keep that in check. So when do you want to give it? You want to give it if there's early onset myopia, progression more than 0.5 diopters per year, or there are other risk factors, strong parental history. In these cases, you can give it in myopia, or even sometimes in pre-myopes, there is a thought that it can be used. There are certain contraindications such as Down syndrome, such as congenital syndromes, heart issues, heart blocks. So they don't want to give it in those cases. So, do not blindly prescribe this drug. Even for things like cerebral palsy and where, the focus may be lost, you don't want to give it. Rarely atropine, when we know in the stronger strength can cause fever, and the milder strength, it can still cause some blurring of vision, though we have not noticed any febrile situation for any of the patients that we have seen. But how do you want to give it? You want to first a certain progression. So you definitely want to have at least 2 visits of that patient with you. Try and do a baseline axial length if you can. A baseline cycloplegic refraction is very, very important. Start with the 0.01% at bedtime. Call the patient in 2 weeks. Make sure they're compliant. Make sure they don't have any of the adverse effects. Make sure that they know how they're putting the atropine drops in the eyes. And then thereon, you can do like a 3 monthly or a 6 monthly follow-up. And after using use at least for 6 months to 2 years, and then you want to taper them. And usually till about 15 years of age, you can easily use atropine. And in fact, beyond that has also been shown, even in, up to young adults, people have tried this. So it's a very safe drug, as we know, that is there. And all these guidelines will be, available very soon through the AIOS to all of us. If you're seeing somebody who's not responding, ensure that they're using the drug, so there's compliance. That's very, very important. You may increase the concentration, and we've got now the higher concentration also commercially available, and modify the environment. So again, like I said, if somebody's continuously doing near activity, not doing any distance activity at all, and you're using atropine, it may not have much impact or much role. So that's important. The ATOM 1 study was what compared the 1% atropine and saw that it had an effect. It reduced myopia progression. The ATOM 2 saw the diluted form of atropine and said that also seemed to work very well. And the LAMP study compared the two, and they found that versus placebo, the atropine actually did better. So these are some of the landmark studies, and of course, a lot more have now come and been available, but that will require a lot more time. So it's a safe option. Low dose atropine is a safe option. You should use it when it's indicated. Of course, don't use it left, right, and center. I've seen people use it even when there's limited myopia, hypermetropia. They use atropine in all those cases. So that's not right. And ultimately, the final thing, that this is very, very important in this slide, is to modify the lifestyle, because if you don't do this, all the other parameters will not work. So reduce the near work. Ask them to spend at least 2 hours outdoors. Ask the children to spend 2 hours outdoors. Near work should not be at a very close range. Keep it at a distance. Keep a good lighting. A good diet is important. Good sleep. A circadian rhythm should be maintained. So all of these have shown evidence of helping in reducing the progression of myopia. And in the final slide, you can see that the efficacy of each of these interventions, atropine is up to between 30 to 70. Then use of these contact lenses, etc., is slightly on the lower side, but use of these special glasses again has shown about 60 to 70%, and use of soft contact lenses or multimodal therapies on the whole has shown as good a efficacy, as much as 70 to 80% in arresting myopia. Again, these are studies that have been done in a certain limited group of people. It may vary for East Asians versus Asians versus Caucasians, because there is a very, very strong racial predilection for your client attention. So thank you, and feel free to get in touch with me, for any further clarifications. Thank you.
Thank you, Dr. Digvijay. It was very nicely presented. We have a couple of questions for you, Digvijay, before anybody else asks any question. I'll just put forward there are two questions. One is that how do you decide about the concentration of atropine? What concentration to be used in which individual?
So by default, we would start with the lowest, which is 0.01%, because the chances of the acceptance is highest for that. Anything more than that, 0.05, sometimes the children find it blur and the parents will very quickly, say that this doesn't work or this is not, my child is not accepting it. It's only non-responders that you think of a higher concentration, or you would give a higher concentration in sometimes in fast progressors. Now that is what the guideline that will come out. You can still consider giving the higher concentration, but as of now, as a default, start with 0.01%.
Okay. And how long should it be given? That is also another thing that's
So
somebody has
minimum
asked.
6 months to 2 years, but usually up till 15 years or 16 years of age.
Okay. Okay.
Dr. Rajesh, I have a question for Digvijay.
Yeah.
Hi, Digvijay. Satanshu here.
Hi, sir. Yes, sir.
So, actually, what difference you find in the Hoya and Zeiss defocus lenses?
So both of them are the concepts are similar. Of course, the technology is slightly different. I've generally seen that, without any financial interest, that Zeiss has had a little additional blur to begin with, which is probably more efficacious, but sometimes difficult for them to adapt right in the beginning. But Hoya has a more long-term data that is available currently for us. Generally, I would look at, you can choose either, and sometimes they have schemes going on and you can guide the parents accordingly, which one seems to work better. But I don't have a very specific, I'm not a stickler on choosing one specifically between the two.
Okay. Any other comment or question? Dr. Partha, are you ready? Okay. Yeah.
Yes.
So,
Sorry, sir, I had to go first. I think just waiting
thank
for you
you,
to
No,
Mr.
complete.
no,
Digvijay.
the youngsters will go first always.
Sorry, Nish. Thank you.
Thanks a lot, Dr. Digvijay. Now we move on to the next speaker, Dr. Partha Biswas, and he'll be talking on femtosecond laser-assisted cataract in difficult and challenging scenarios.
Shall I share my slides?
Yeah,
Rajesh?
please go ahead.
Sure. Is it shared?
No.
Not yet.
Okay. एक minute. Is it shared now?
Yes,
So it's
yeah,
not visible. It is saying it is shared.
Shared now?
No, it's not
No.
visible, but it is saying it has started sharing.
Acha.
now
Yeah.
visible.
Perfect, sir.
Now done? Okay.
Yes.
Yes.
ठीक है. Thank you so much. So, thanks you very much, FBS and Professor Rajesh Sinha and Dr. Rajiv Mukherjee, for giving me this opportunity to be here with you today. And it is something of a great service that FBS is doing for the entire AIOS community. And I think this is human service that is being conducted. And so many people, so many of our members and their families have benefited from the FBS scheme. On this note, I would really request all our members to pass on the good message and have FBS become a very strong project in itself so that more and more members can benefit from it. So coming to the difficult situations in flax, and flax has situations in which now today it is a very standardized corneal procedure, and it is perfectly centered and around capsular axis, lens nucleus fragmentation even in hard cataracts, and that's a very big benefit because the amount of phaco-energy that is delivered into the eye comes down. Astigmatism control is again a reality to an extent, of course, and real-time optical coherence tomography with the software, it's a very precise aspect in which the flax is done and the recovery is definitely very fast. But we need to plan, we need to engage, we need to customize, and then we need to treat. So, with all this in mind, let's look at why flax. And flax has its benefits, and now there are no doubts to it. The huge benefit that flax has in difficult cases, in challenging cases, where it scores much above the uh, the importance of the phacoemulsification. So let us look at a few scenarios, and this is a hard cataract surgery in which we are opening up the ports, and the ports are open. At times it does not open, especially the side ports, and then you can resort to incision. But look at this very hard cataract in which the amount of phaco energy that would have had to be used would have been enormous compared to what we will be using now. So a gentle hydrodissection, a rotation, remembering that these solules are going to be very, very fragile. So as minimal as possible of the maneuvers within the bag and moving it as gently as possible. Of course, the speed of this video has been a little increased, enhanced, but you can see that all the pieces, and here we have carved out sextants of this, and they are opening up quite well. So once this opens up, so it is not only creating the pies without much of effort, but it is also giving way to the amount of the phacoemulsification delivery within the eye much less. And you can see that it becomes quite easy to remove all the nucleus fragments. Softening of the nucleus fragments also can be resorted to, and definitely that also reduces the intraoperative phacoemulsification energy. So once we come to the last piece, we need to be careful as in phacoemulsification. You can see that the hydration is occurring in the main port incision. Usually I take off the side port instrument, and usually the solubility is so good that we are able to remove the cortical aspiration and the last piece. Here it's a hydroimplantation of an intraocular lens, and we place in this intraocular lens in the bag very gently. So once it goes in, next day, of course, it is a cornea that is something much better than would have been with just phacoemulsification. Now, there have been a lot of thoughts in which can a rhexis in a flax extend. So let's look at this video, a pretty old video. You can see it from its Signature Pro that we have been working on. Uh, but once in a while, very, very rarely, will a rhexis extend. But of course, if you have been a little not so diligent with the maneuvers within the anterior chamber, if you brush against the capsule, then it can actually run out, or it can rip open the rhexis. So here it's grade 2, grade 3 cataract, and we are going ahead with phacoemulsification, and everything has gone on well. Everything was quite otherwise gently done. But what we do see is there's a possibility of this arrow shows that this rhexis has run out here. So whenever this happens, one needs to be very careful, and one needs to put in the viscoelastic in the anterior chamber, and then remove the rest of the cortex, whatever there is, and placing the lens inside the bag again with all gentility. And here, as we place it, it needs to be placed at a perpendicular axis to where the rhexis has actually gone out. So with this in view, so this is a particular case which is quite rare, but I thought I would present it. Let's look at this important case where it's a subluxated cataract, and you can see that a subluxated cataract as this, there's hardly 2 millimeters of the anterior chamber. So the whole lens is getting subluxated into the anterior chamber. And this is how we need to take it up. And once you can see how well inside it is, you can see the side port instrument going and impinging on the anterior capsule. So one has to be very gentle. And just imagine if we had to carve out a rexis in such a shallow anterior chamber, it would have been so difficult. So here, the subluxated in the subluxated cataract, it becomes of a great importance that we place in. We have a capsular axis well in place, which is neat and round, and we also have a nucleus dissection in place. So, with this in mind, what is important here is, of course, a very gentle rotation and to see if the subluxation will extend, and then placing in the CTR as and when required. Here, in this case, we are able to get along with the phacoemulsification, and whenever it is required, we'll put in the CTR in this particular patient. So here, I feel now the subluxation might increase a little, and I place in the CTR. And once the CTR is in place, then it's important that we take off the rest of the fragments from the bag, and the bag itself is a stable bag at this point of time, and no amount of subluxation has decentered it. The CTR has well connected to it, and it's a stable bag as of now. So we place in the intraocular lens, and the intraocular lens gets well placed inside the bag. So in such cases, a femto assisted cataract surgery is of great importance. Let's look at this another reality, and that's the posterior polar cataract. With the posterior polar cataract, you can see the dehiscence here, and it is important that we carve out the nucleus and do a nucleotomy, the femto-assisted nucleotomy, beyond the dehisced area. So here again, it's very important to do a hydrodelamination, not a hydrodissection, and very gently. And once this is done, then we have the nucleus well supported, and the epinucleus is actually supporting the posterior pole. So here, of course, we have a good rotation as well, and the nucleus comes in quite well. And once the nucleus comes in, we definitely know that this has become important. And placing the intraocular lens inside the bag, always remembering the fact that this intraocular lens was placed in hydro also, and it's important that we very gently go around it, because a dehisced area in the posterior pole can totally give way at any point of the time, even during hydro stitch of the capsules or the incisions. So this again, posterior polar cataract is an important aspect in which we definitely must do a femto if it is possible and if it is available. Let's look at this ICL explant with a phacoemulsification of the IOL. Now, as we dock the implant, what I need to tell you is that it's important here, and I'll stop the video at this point of time. So it's important to actually ascertain not the it's actually important to ascertain the anterior capsule or the anterior surface of the cataractus lens. By default, at times, the femto laser will actually ascertain the superior part of the ICL or the superior surface of the ICL. So this has to be brought down manually. And once
Dr.
it is
Partha, your file is not being shared. It has got unshared.
oh, it's got unshared. Is it? Has it come?
You're going to slideshow mode, sir.
Yeah.
Slideshow mode. Okay, well, 1 minute. Yes. Okay.
That's
Yeah,
it, sir.
it's fine.
Okay,
Perfect.
fine. No, I'll just go back to where I was, and I'll put it.
Yeah.
Is this better?
Yeah.
Okay, fine. audible also, no?
Yes, yes.
Okay, sorry. So, as I said, this is the docking, which is very important, and it has to be done manually. And this is what we are doing it at this point of time to be very appropriate on the lens capsule. And again, the importance of having the ports is also there. However, the ports can be taken off or disengaged. So here, this is the right way to scan the capsule with the anterior OCT. And once this is done, what we need is a capsular access, and the capsular access can be done well. So we remove the ICL, which is again not so difficult, under cover of viscoelastic, including high molecular weight is viscoelastic. And once this ICL comes off, all that we need to do is to remove the cataractus lens. And here, since it was a very high myope, we placed in a multi-piece lens which was available, and that makes it quite simple. Now, here is a case in which, again, it's a very rare case, a skipped capsulotomy. We had, this was one of my first cases, and what we had done is, what I had done is, by mistake, I took off the foot pedal and pressed it back again and kept on pressing it. So I'd skipped the capsulotomy, and here I'm making a manual capsulotomy. And then, however, the nucleus dissociation was already done. And it is actually a myth that the nucleus dissociation, with all the bubbles coming in, can actually burst open the capsule, which it does not usually do. So here again, this capsulotomy got skipped, but we are able to complete this capsulotomy and remove and place an lens within the bag. Now, the last case that I'm going to show you is this one, and it's a microspherophakia. Again, a very, very difficult case when it comes to the capsulotomy. And the capsulotomy itself, you can see that it is like a absolute residulla of the lens, nearly a spherical lens in place. So we just want to do a capsulotomy in this particular patient, and once the capsulotomy is done, then we need to take out we are doing the Hoffman's pockets, and once the Hoffman's pockets are done, so this is actually the capsule that is getting
Sir,
taken.
can you mute your music, because you're not being heard
Yes.
very well.
The
Thank you, sir.
capsule is taken off, and one has to be very gentle about the taking of the capsule. Here, the iris hooks are actually used to anchor the capsule, because the flanges of a capsular hook will not fit into this very small bag. Though we have taken the help of the iris hooks, which have to be very, very gently done, because as we know that hooks are actually have ends which are quite sharp. And then the intraocular lens is placed inside the bag. It's a single piece lens, and then with the single piece lens inside, we need to anchor this bag. If it is not anchored, the very deficient zonules that there is in the microspherophakia will at any point of time get dislodged, and there might be a luxation either on one side, or even at times the whole bag can come into place. So here is a well anchored bag, and in microspherophakia, flax definitely has a great importance and significance. Thank you very much for your patient hearing.
Thank you so much, sir. That indeed was a fantastic presentation, an eye-opener indeed, and I'm sure Rajesh will have a couple of questions coming your way.
Yeah, that was really interesting. But I would like to have comments from some of our panelists first. Maybe Zan, would you like to say something?
Thank you, sir. Very good series of cases, Partha, sir. Lot of learning points for all of us youngsters. I just wanted to know from you, from your experience, the contrary to this, do you feel that in certain situations doing femto actually was worked adversely as compared to have doing a normal phaco? Maybe you can shed light on some small pupil or some other instance like that.
Yes, and thank you for bringing this up. All patients are not amenable to flax, and at times a patient with a small pupil can come and say, "I want to get flax done." So there have been instances that a patient wanted to get flax done, and the capsulorhexis that we could achieve was just about 4.2 millimeters, right? But a 4.2 millimeters capsular rhexis, and if it was a posterior polar cataract with a 4.2 millimeters capsular rhexis, still an advantage is there. So with this advantage in mind, but a 4.2 capsular rhexis definitely has to be enlarged after you have placed in the lens, or before placing in the lens also. And you need to assort to either hooks or devices, and make it a larger pupil for the rest of the procedure to go on seamlessly. So these are certain possibilities that can occur. But however, even if it occurs, then this can be taken care of. There are certain times that you really cannot do flax, and then it's best to refuse. And that is if there's a corneal opacity, if there is a possibility that you might miss the capsulotomy. So such instances, definitely flax is not the answer to a capsule to cataract surgery.
That was
Thank you, sir.
very well answered, actually. Zan, I would just like to add one thing here, that some patients do ask for flax and then you have to do it. So I have done it once in a small pupil after putting Malugan ring in the eye to enlarge the pupil. And the only thing, and I've injected high viscosity viscoelastic. So the only thing is that if the incision is up to 2.2 millimeters, then you can use high viscosity viscoelastic, but you'll have to use higher energy for laser energy for doing the flax. That is one thing. Or sometimes even people have used put suture to close it and then have done it. And I mean, these are sometimes compulsions. But yes, that's very true. If it's a small pupil, you can very well do manually in a very nice manner. And very nicely pointed out by Dr. Partha that, in conditions like corneal opacity, I mean, when the visibility is not that great, then obviously it's a big challenge.
Also, sir, I just wanted to know, you spoke about the tensile strength of the capsulorhexis. Do you feel that in a hard cataract, because it was a femtorhexis, it may have given way and extended, and a manual may not have, or there's not
No,
much?
not really, Zen, because we continue to doing these hard cataracts, and we don't find the rexis extending. But this was, I think, of so many cases that I would have done over so many years, there would have been just about a handful, maybe three or five of them that would have extended. So it's usually a good capsular rexis, and it does stay well also.
Thank you. Thank you, sir.
Any other comment from anyone?
It's one thing I wanted to know is that the dangers of using an iris retractor in place of a capsular hook is that the leading edge of the capsular iris retractor is sharp, it's not blunt. So if
Yeah.
your chamber shallows and your posterior capsule in the periphery hits the capsule, the leading edge of the iris retractor, we may not have a issue at hand.
Yeah, true, Rajiv. Again, at one time we used to use the iris retractors when we didn't have the capsular hooks. And though they are sharp, you have to be very, very careful. But again, remembering the fact that a microspheric bag, you don't have a possibility of that large flange going into that little thin rim of the capsule. So all that you can use is the iris hooks. And because it's a flaccid bag, so the possibility of a tear is not there unless you have really stretched it very hard. So these small things, I think, on the table itself, one is able to maneuver. But it's definitely an issue. You have to be very gentle and careful.
Yeah, microsphericity, I think, is a good indication for doing flax, microsphericity or subluxated cataract. I have also done both the eyes of a patient. At that time, we had that portable machine, femto machine, that had come for demo in our OT. So I've done that, and that was published in American Journal of Ophthalmology. So it works quite well even in subluxated cataracts. It works well. Only you have to decenter the rexus towards
Yeah.
one side slightly so that your rexus finally is well centered. So flax does have a lot of advantages. Yes, I think even without that, people have been doing very well. But yes, it does have advantages in complicated scenarios like operated VRs or wherein you are mute, sir. Sir, you are mute. You have to unmute yourself. Yeah, and yeah, that's true. Any other comment from anyone?
I think it was a very comprehensive talk, so I guess there's not anything much less to be said on that. And we're extremely grateful to Partha sir for agreeing to come and enlighten us on this fantastic issue
Thank
with
you
a
very
wonderful
much.
presentation.
No, no. Thank you so much, Rajiv, for giving me this opportunity. Always very happy to be there. Only that I would like to excuse myself. There's another meeting that I have to join right now. So if you don't mind, may I please be excused?
Okay.
Thank you
Thank
so
you,
much, sir.
sir. Thanks a lot.
Thank
Thank
you.
Partha,
you.
what I noticed, you are looking at the laptop
Haji.
from the near vision. So get your glasses check again.
अच्छा सर, ठीक है, कर लेते हैं सर, कल ही करवा लेते हैं।
कल कराइए, check ही कराइए.
जी।
Okay.
Thank you,
Thank you,
Partha.
sir.
Thank you, Partha, for
Thank you.
joining.
Thanks a
Thank
lot.
you.
Thank you.
So now we move on to our next speaker, the last talk of this webinar, and which is about a very important issue that is a very important topic, that is family benefit scheme, a scheme which is really very popular amongst a lot of AIOS members. And we have with us the past chairman of FBS AIOS, Dr. Quresh Muscati, who will be talking about why one should join FBS AIOS, what's the advantage, and why you should take it as your partner.
Thanks, Rajiv. And with a little help from my son-in-law, as I'm at my daughter's home, I'll just share my screen. Yeah. Am I visible?
Yes, sir.
Is the screen visible?
Yeah.
Yeah. So this is everything you wanted to know about FBS AIS. Did not know whom to ask, and more importantly, for those who are in a little bit of apathy of why should I ask. So what is so unique about this family benefit scheme and how did it come up? I'll give you a little bit of the history of this scheme as well. One sec. I will. So what is the aim of FBS AIS? It's to provide support to the family after the demise of a scheme member. Please understand that for those who compare it with life insurance and other schemes, those are very professional schemes meant to make money for the corporation which is giving those schemes. They are reluctant to part with their money, obviously because they want to keep profits for their shareholders or whatever. Our primary aim here is to provide support to the family, and family of whom? Family of AIS members, because this scheme is only for AIS members. So if a scheme member, one of the members of the family benefit scheme passes away, we want to provide immediate support, not after 6 months, not after 1 year, not after haggling with them. You haven't provided the 17 papers that I need, 14 documents that I need. I'm sorry, I can't give it to you. Nothing of the sort. Within a month, the money must reach the family because that is when they need it the most. So, and to lessen the financial burden on your loved ones in your absence. So, if you are a member of the FBS scheme, we provide a handsome lump sum amount as benefit to your nominees on your demise. Currently, it is rupees 25 lakhs. These are the 4 bottles we use at different stages of life: the milk bottle, the Coke bottle, the beer bottle, and the IV. And after some time, nothing works. So when you are no more, the 5th bottle will be the bottle coming of 25 lakhs from the FBS, AIOS to your family. Why is this scheme unique? No other scheme from any company, including LIC, which gives such an assured benefit of 25 lakhs for such a low one-time joining fee. And the joining fee has been reduced, has been slashed by over 80% on the demands of our members. So we are a very member-centric organization. Every time we have a general body meeting, we listen to what the members are saying. They said to get more members to join, let's slash the joining fee. The joining fee was in the thousands. We've reduced it to something like 299 rupees, less than 500 rupees for most people under 40. I'll talk about it. So just a small one-time joining fee and a small annual contribution. We call this the fraternal contribution. Fraternal means for our family. So we are giving a fraternal contribution, which for if you're a youngster who's joining, it is only 300 rupees. For the regular members, it is 600 rupees per death. So assuming that 10 people die in a year from the scheme, your contribution is only 6,000. What happens to that 6,000? That 6,000 is joined with all the 5,200 active members who are there, and a sum total of 25,000 has gone up. I'll give you an example. When we started the scheme in 2004, which is 22 years ago, we had 900 members to start. That time, what we call the mortality benefit or death benefit, which we gave, was a mere 50,000. So from 50,000 in 2004, it has gone up to 25 lakhs in just 22 years. As the membership increased, we consult our financial experts called actuaries, and they guide us as to how much we can increase the mortality benefit. So as I said, the scheme started in 2004. First two deaths occurred in 2005, were given death benefit of 50,000. At that time, there was no age limit in the first year. My father, Dr. B.T. Maskari, joined at the age of 78 at that time. When he passed away in 2016, his nominee, who was my sister, got 22 lakhs upon his demise. So it is amazing because his total contribution over the 18 odd years that he was there in the scheme must have been just about a lakh or so, and my sister got 22 lakhs. Now, of course, there is an age bar, so only youngsters below the age of 49 can join. We're trying to bring the age bar even further down to ensure that we can get more younger people in so that they survive longer, pay more fraternal contributions every year so that we can increase the amount given on death benefit. Some important points. You need to be a ratified member of Aios to reap the benefits of this scheme. So you must join Aios first. I'm assuming that you're all members and you're ratified in the first general body meeting that comes in after you join. You're a ratified member. You can fill the form online along with Aios membership form. You can fill this as well. The website is very easy to navigate, or you can download and fill it offline. You have to submit a few proofs, very few proofs that you have to submit. Even a health declaration is a self-declaration by you that you're in good health. Unlike LIC and others, we don't force you to go for an executive checkup costing 10,000 rupees and with X-ray, ECG, all that. We just ask you to tell us the truth that you're in good health. Your joining fee is age-related, like macular degeneration is age-related. It starts from a mere 299 if you're less than 40 years onwards and goes up a little bit with increasing if you're less than 40, and up to 49 it goes up a little bit. Your fraternal, people have asked me, what about tax? Is it? Yes, your fraternal contribution is tax deductible, just like any insurance scheme. Also, the mortality benefit which we give to your nominees is tax-free in their hands. Also, suppose you have a serious health problem. You're over the age of 65, you've been a member for 12 years or more, and you need the money genuinely now. You can exit the scheme at any time after providing you're above 65 and you've been a member for 12 years, and you will receive 4 lakhs, no questions asked. If you've been a member for 20 years, because the scheme started in 2004, so people have finished 20 years, and you wish to exit, and of course you're above 65, you will receive 7.5 lakhs. So it's a huge difference from what you've paid. 1 to 1.5 lakhs is the max that people have paid from over 20 years. You straight away get 7.5 lakhs for your medical needs that you may have. Of course, all this goes to your bank account. It's legit. There's no demonetized currency notes which are there. So some important points regarding your nominees. Again, these are a lot of questions we get. Yes, you can change your nominees anytime, any number of times in your lifetime. You could be married to somebody, your wife, your spouse could have been your nominee, and then your spouse may pass away. You may want to change the nominee to your children or to your new spouse or girlfriend or whatever it is. You can do that. In fact, we encourage you that if your nominee has passed away, please inform the FBS office and change your nominee so that at the end, if you were to pass away, we must have a nominee who's alive to give your death benefit to. You can appoint up to 3 nominees. So either 1, 2, or 3 nominees. In case you appoint more than 1 nominee, the death benefits will be split equally between the nominees. You cannot tell me that you give 67% to my son and 23% to my daughter and the balance to my dog. That's not permitted. So we will be splitting it equally between the nominees, and it will be given strictly to the designated nominee. I'm telling you this because we've had cases in the past where the nominee says, give it to my sibling needs the money more, I'm a rich man, I don't need it, please give it to them. Sorry, if you are the nominee, we will give it to you. You can then pass it on to your sibling. That what you do with that money is not our lookout. So make sure that it's only we will be giving it only to the nominee, even if the nominee says give it to someone else. And the nominees are different from what you write in your will. In your will, you may have mentioned anybody, but in the when you filled up the family benefit scheme form, the nominee that you mentioned is whom we will give it to. Even if your will says give all my assets to somebody else, these are not your assets. These are our assets we are holding for you and we are sharing with your loved ones. So there's a difference. So you must, the nominee is very important. You must send the nominee details to the office with your form, and you must remember to change your nominee in case you wish to or the nominee passes away before you. Another important thing is the nominee must have an Indian bank account. We've had problems where the doctor has passed away and his one son is in New Zealand and the daughter is in France, and neither of them have an Indian bank account. We can't give it to them. So please make sure that your nominees set up Indian bank accounts while you are alive. Make sure that your nominees have Indian bank accounts so that later on we will have no problem. Our website of FBS Aios is very user friendly. It's www.fbsaios.in. I urge you to go and visit it once. It's been completely revamped. You can make all payments for your fraternal contributions, what we call FC, through the payment gateway which is on the website. We very much appreciate online payments. It is seamless, quick, and there are no additional charges levied. If you pay by credit card, of course, the credit card company, there is a small surcharge, but we encourage you to pay by NEFT, RTGS, whatever. So it's very, very quick. Checks are not appreciated. They take time to come. We have to trust the postal service and things like that. Cash you can give we normally have an FBS stall at the Aios conferences and at many state conferences and specialty conferences. So if you do find a stall there, we will have our own people there. They will accept the cash and give you a receipt. Make sure you take the receipt. So I urge you to join FBS now before you get age barred. Feeling frustrated later, which has happened now. There are people who are 50 and 51 telling me, please open it again for us. We are willing to pay any amount. So it becomes very difficult to keep on opening the scheme. So it's better that if you're before the age of 49, you're not yet 49, please jump in and join. Either visit the Aios website and come through there or visit our website directly. It's extremely simple and extremely less paperwork is required, and you will not regret this decision ever. I'll be delighted to answer any questions. Thank you so much for your attention.
Thank you so much, sir. A couple of things that I'd like to add on to what you just said, which was comprehensive to the best that I can ever imagine, is that we all need to know that FBS AIOS is run by AIOS members. who are FBS members as well, for the best interest of our own community and their family members. Number two, something like exit scheme that Kuresh mentioned is not available in any term insurance policy in our country. Number three is that FBS AIOS, we have a 100% claim ratio. 100% claim ratio. We have not denied claims to any family till date. Number three, that when you pay online, you can use the scanner there, QR code scanner there, and your there'll be no deduction of any additional charges apart from your UFC. Number four is that in case, as Dr. Kuresh said, we have faced this issue about nominees not having Indian bank accounts. We always encourage them on the next trip to India to open an NRE NRO account, and then we can transfer the same amount that is due to them in their NRE NRO account. So thank you, sir, for this fantastic overview of FBS AIS. Professor Rajesh will take over now.
Thank you, sir. It was
Can I add a point here, Rajiv?
nice coverage. Yeah, Maniar sir.
Yeah, just one or two more points about FBS is that all our systems are audited periodically. All our policies go through an actuarial analysis every second year. And there is an independent systems audit of our entire structure in terms of our finances and even our governance and our day-to-day functioning. So not only is it totally above board, but it is also audited periodically by external people. This is something where you can rest assured that your membership is for your benefit only, and no member or office bearer of the FBS is offered or takes a pie to attend any meeting or to go anywhere or anything of that sort. Everybody works voluntarily. Thank you, Rajiv.
Thank you, sir. Any comment from any of our members, any of our office bearers who are with us?
Sorry, we have to make understand all that this scheme is for their colleague. So they should not think much about the interest or whatever they are getting. They are getting better than anything else. But they should always think that they are supporting their colleague. So this is the most important thing about this scheme, that they are supporting the family of their own colleague. So we should never hesitate in joining this scheme.
That's so right, and it's not only their colleagues that they're helping; it's their own family when they're not there. When FBS will
that is
step
more
in to
important.
support you.
Family is not there, then colleague is not there. We're helping their families. This is the most important thing about the FBS.
Okay, so with that, we come to the end of the webinar, and can I request Maniar sir, are you there?
Maybe Kuresh sir can guide.
Yeah, I'm here.
Yeah. So
No.
concluding remarks from you, sir, and
And actually, Kuresh and Rajiv have spelled out everything about FBS so well that I think it's important for every junior eye surgeon who joins the FBS to also, or who joins the AIOS to join FBS simultaneously at the same time, because with your ratification, your FBS membership also gets confirmed. You get the benefit of joining in as a young person where your outlay per death is much less than if you joined later. So the request to all the youngsters is, please join. The minute you join AIOS, join FBS also. Thank you, Rajiv.
thank you,
Rajesh.
sir. And we have with us Dr. Digvijay Singh also, who was the president of EOC when we had launched this scheme, I think 3.5 years back. And there was a good addition of young members, but then after that, the addition was not that high. So I request Dr. Digvijay to, put in a word to his colleagues. I mean, to the current UC team, so that the benefit of this wonderful scheme is passed on to all our younger members, as well as, of course, those who are mm, less than 40 or less than 30, wherein we have special schemes, special admission fee, minimal admission fee for them to join. So I'll request you to put in a word to the younger colleagues.
Sure, sir. Sure. I think even Zen is here with us on the panel
Yeah,
as well.
Zan is also here.
Yeah,
Zan, will request you all to put in a word to your friends, your younger colleagues in the YOC, and
Yes, sir.
all your friends, so that this is a
Actually,
wonderful scheme.
Zen is a go-getter. You give him a target and he's flexible.
Yeah,
Actually,
Yes, sir.
Digvijay will request you to put a talk at the prime time in your Yossi session. Whenever you have a Yossi conference, you put a talk of the Yossi. Anybody can come from us, or you can speak. We will give you PPT. You can speak in the prime time, and you give a stall there also in the prime location, so that we can propagate among the young. Because you people are deserve more, and you need more this type of scheme to join.
yeah,
That we have to make them understand.
yeah,
Thank
yes, sir.
you.
Sure.
Yes.
Why not?
yeah.
Yes.
So,
So,
Rajesh, can I just
yeah,
give a small vote of thanks to you, to Rajiv, to Partha, Kuresh, Zen, Dr. Digvijay, Satanshu, and all of the people who have attended this webinar. I think not only was it informative about science, but also about your social benefits that you get out of the FPS. So thank you
Bill,
one and all. Thank you again. And
बहुत
we
खाली
look
है
forward
कितने
to
हैं
your attendance in our further endeavors. Thank you.
thank you, sir.
Thank
Thank
you,
you
sir.
all.
Thank you, sir.